And I request the next speaker to keep their presentation ready on the other podium. Sir, please come this way. So Dr. Sarab Chhabra will be presenting on novel perspective in choroidal osteoma. Can I confirm who are the speakers that are present in the hall, please? Please raise your hands. Name? Okay. Thank you.
Good morning to the esteemed panel and all the delegates present in the room. Choroidal osteoma is a benign ossifying tumor of an unknown etiology, which is characterized by mature bone replacing the choroid. The purpose of this paper was to report a diagnostic dilemma in a case of a chorioretinal lesion. A 28-year-old female patient presented with painless progressive blurring of vision in the right eye of a duration of 5 years. Symptoms of this blurring started at 5th month of pregnancy. Only the right eye's vision was affected. It was finger counting 1 meter for distance and N24 for near. RAPD was observed in the right eye. The cornea, iris and the lens were normal. On retinal examination, both eyes showed orange-red peripapillary lesions deeper to the retina with marginally defined scalloped margins located within the macular area. The right eye additionally showed presence of fibrous scarring and clumping of brownish black pigments in the foveal zone. The retinal vessels and the peripheral retina were unremarkable. This is the fundus photograph of both the eyes. On investigation, an ultrasound B scan was done, an CCT orbit was done, and in the end an FFA was also done. The ultrasound B scan and NCCT orbit had similar findings showing bilateral linear echogenic foci and bilateral curvilinear calcifications along the posterior wall of the eye, both of which suggested bilateral choroidal osteomas. Hematological investigations showed a raised ESR, raised TB1 and TB2 values on ELISA, and IgG markers positive for rubella, CMV, and herpes simplex virus. This is the ultrasound B scan photograph. There as a posterior echogenic, there is a shadow which is observed. These are the corresponding FFA images. For treatment, usually the only treatment which is given is observation if there is no progression of disease or any neovascular membrane is not observed. So in this case, the patient was started on eye drop nepafinac and indomethacin capsules and multivitamins, which were given only for 1 week to begin with. Anti-tubercular therapy was also started on the first weekly follow-up. The patient was called for follow-up weekly for a period of 3 months. The patient responded to systemic and topical anti-inflammatory therapy. Vision in the right eye improved for distance as well as near. And during this period of follow-up, multiple retinal imaging and scans were done, which showed that there was no development of any CNVM, hence no intravitreal anti-VEGFs were advised. The radiology suggested choroidal osteomas, but the presence of systemic tuberculosis may have had an etiological contribution to the diminution of vision, hence why the patient responded to anti-tubercular therapy as well as anti-inflammatory therapy, which was given along with. This statement is corroborated by the improvement of vision. Usually choroidal osteomas are only observed if there is no progression or growth which is seen along the margins, but they are also associated with multiple systemic conditions. So there should always be a high degree of suspicion when choroidal osteomas present to us for systemic diseases which may be present in the patient. So adequate control and early detection of those diseases can be done for proper treatment of the condition. Also, we should be on the lookout for any sequelae of RPE atrophy and choroidal neovascularization which may occur, so that intravitreal anti-VEGFs, if required, may be given. Thank you.
Thank you.
Thank you.
So, thank you for the presentation. I wanted to know what was your differential when you saw that patient?
Sir, when the patient was examined in the OPD and indirect ophthalmoscopy was done, the first treatment or the first investigation on the day itself, we had sent the patient for a B scan, and when that showed shadows behind the retina, so the first differential was any sort of calcification. So the first differential was a choroidal osteoma, and others were chorioretinitis, any other form of any other chorioretinitis.
Any form of any role of FFA and ICG in this first?
Sir, FFA. So when we were thinking, when the chorioretinitis was in the picture, a late chorioretinitis was in the picture, then that is why the FFA was done. But there was no characteristic hyper or hypofluorescence which was seen, which would suggest or go in that direction. And the B scan images and the NCCT images were already available at that time, which had showed calcification. So we did not progress further in that direction.
Did you do anything else, any other tests like an ultrasound, and did you rule out any other systemic conditions in this patient?
All the any other systemic conditions like
Any other systemic associations along with the osteoma that you showed in
no,
the body?
Ma'am, only the tuberculosis and the basic because it started during pregnancy. That is why we did tests for TORCH and TB having high predisposition and prevalence in our country. That is why we tested for TB by ELISA.
I just want to know one thing.
Yes,
Why NTTB was started?
Ma'am,
Because the choroidal osteoma, they have very particular picture.
Yes,
So
ma'am.
that is very specific,
Yes,
and the calcification you have shown on the B
Yes,
scan,
ma'am.
that is very specific for the
Yes, ma'am.
that is the osteoma. And why NTTB was started?
Ma'am, because the patient had raised levels of TB1 and TB2 on ELISA, so it was started for the patient was treated for TB along with.
But the patient was pregnant also.
No, sir.
Yes.
The symptoms started when she was 5 months pregnant. This duration of diminution of vision was 5 years. The
5
symptoms
years.
started when she was 5 months pregnant.
And
you completed the course of TB, or you left it in between?
No, sir.
Just
The
15 days.
so she is currently under treatment.
Okay.
So this patient presented to us about 5 months back. So currently she has not finished her 6 months of TB treatment.
I think you said that it was initiated, but then was it completed?
Sorry,
What is
sir?
the role
Ninth
of
month.
completing it also?
Yes, sir. When the patient is expected to come to us next month, then we will again do follow-up scans. Sorry, sir. The TB treatment, you mean?
Yeah.
Yes, sir. It has been initiated, and the patient is undergoing treatment for
So I
tuberculosis.
think, as even ma'am was asking, were there any systemic associations, anything to do with tuberculosis that you initiated, and then you've continued the TB treatment?
Sir, just cough and poor appetite. That's it. The patient did not have any other symptoms which would suggest for tuberculosis. It was just a general checkup that we did, which showed raised tuberculosis 1 and 2 levels on ELISA.
Okay.
Can I just ask,
Inoculated in loss resistance media and you demonstrate the stuff.
Sorry, sir?
Can I ask Dr. Deepti to take the podium?
I mean to say that did she have a pulmonary tuberculosis or extrapulmonary tuberculosis?
Sir, probably extrapulmonary because she did not, apart from cough and a diminished appetite, the patient when she presented to us, she did not show any other features.
So she was put on ethimetol.
Sorry, sir?
Was she put on ethimetol?
Sir, we referred the patient to the, from what I know, sir, she was not put on thimetol. The regular rifampicin, pyrazinamide, isoniazid, the regular therapy was started.
No, the thing is that in the modern,
can start with the
at
next
present, the mode of treatment is ethimetol.
Yes, sir.
But when you put basically on the ethimetol, you have to basically see that ethimetol does cause color changes,
Yes, sir.
changes in the fields.
Sir,
It does cause optic neuritis, which is dose dependent. So all the treatment,
sir, yes, sir. Sorry, I did not hear you clearly. Yes, sir. The patient is on ethambutol. We have also given her. Every time she comes for follow-up, color vision is also done, and she is also.
You chalk the optic disc?
Sorry, sir.
I mean, you chalked the fundus, particularly the optic disc, because the thimerosal is known to cause optic
Yes, sir.
neuritis,
Yes, sir.
which is dose dependent.
Yes, sir.
And if you reduce the, if the onset of
Yes, sir. So that the retinal examination is done every time when she comes for follow-up.
thank you.
Dr.